Professor of Population Health Sciences, as well as the Director of the Office of Global Health Education. And this is the Global Health Grand Rounds. And we have with us today a colleague, friend, Dr. Douglas Nixon, who's going to be talking about a topic that is so timely that I can't even believe that you know, when we started talking about what would you like to talk about weeks ago, if not months ago, you know, we arrived at vaccines. And here, just this week, we have, you know, wonderful news about not one, not two, but three very, very promising vaccines for COVID. So the topic is absolutely timely. Our speaker is very well credentialed to talk about this. Dr. Nixon received his bachelor's from University College in London, his MBBS from Imperial College, also London, and his master's and PhD or DPhil from Oxford University. He is an internationally recognized cellular immunologist who really has been at work on the HIV/AIDS field since, I guess, the early 1980s, where you focused on cellular immune responses to HIV, if I'm not mistaken, Doug. So what we'd like to do is hear from you. I understand we've had you know, email chats before this that you actually had to update your slides to reflect the news about these new COVID vaccines. So really, without further ado, because this is a very, very timely topic, I'm going to turn over the slide deck to you. And to begin, I want to ask, please, of course, that the audience keep their microphone on mute, that please use the chat to ask questions, and also to sign in using the link provided in the chat that Savita sent to you in order to receive CME credit and so forth. So please welcome virtually Dr. Nixon, who's going to be talking about COVID-19. Can old vaccines have new tricks?
Well, thanks very much, Maddie, for that introduction. And I really appreciate the invitation to talk to you all today, and particularly, Maddie, your prescient knowledge of vaccine futures, which came real today and over the past week. So I think we are all getting used to virtual meetings, but I'd like to bring us together towards thinking about what it will be like when we can all meet back together in the future. And indeed, the topic that I'm going to cover today is one way we think we can help bridge the time until widespread rollout of the COVID vaccines occur. And my talk is called COVID-19, Can Old Vaccines Have New Tricks? And the virologists listening and watching will notice that there's influenza virus in the top left-hand corner and the coronavirus SARS-CoV-2 in the bottom right. And hopefully that will be explained during the talk of the course of the talk, and a nice illustrated from the New York Times on COVID-19 in the top right. So my disclosure is that I have nothing to disclose, but I will be talking about potential off-label usage or potential off-label usage for licensed vaccines. And this work, I'd like to get important acknowledgements out first. Started with Rob Schwartz and with Daniela Marin Hernandez, a postdoc in my lab, and Nathaniel Hupert, who is at Weill Cornell Medicine. And it's really been a fun, instructive, interesting, and collaborative journey with my friends here. And then also had some really important discussions with John Kurtz, Fabio Leal, Lishna Volo, and Ben Tenover. So I'd like to start by reminding ourselves about the short history of SARS-CoV-2. And I am still amazed that we are only a few days away from the first year from the first recorded case in China, in Wuhan, 8th of December, 2019. And doesn't it feel like a longer than a year has passed? So if we look back on the timeline, December, the end of December last year, was a report of 29 cases of pneumonia with an unknown cause. And it was only a few days later, 9th of January, where it was announced in China that a novel coronavirus had been identified as the causative agent of the pneumonia outbreak. And then it wasn't long thereafter that the global health nature of this talk comes out, and a traveler from Wuhan was confirmed to have this novel coronavirus infection in Thailand. And then a series of events happened. Human-to-human transmission was confirmed, and 23rd of January 2020, the city of Wuhan, a large Chinese urban city of more than 10 million people, was locked down. 6 days later, it was known that that coronavirus had spread to all 34 provinces across China, and at the end of January, the World Health Organization had declared a public health alert. In February, the International Committee for Taxonomy of Viruses got together and they named the virus SARS-CoV-2 and the disease, the clinical disease that it caused, COVID-19. And at the end of February, the World Health Organization increased its assessment of the risk to very high on the global level. And in March the 11th, 2020, COVID-19 was defined as a pandemic. So forward to today, there have now been over 58 million recorded cases with more than 1.3 million deaths. And if we look at the Johns Hopkins map from today, we can see that that number of cases is rapidly approaching 59, probably will be 59 tomorrow, and we are in a rapid acceleration in a new wave of infections that's occurring around the world. If we look at the cases by country, the United States has been the worst hit in terms of absolute numbers, with more than 12 million people in the United States having been infected, followed by India, Brazil, and then countries in Europe like France, Spain, I was going to say the UK, but that's in Europe just for a short period more, Italy, and then other countries like Russia. And then in South and Central and even North America, Argentina, Colombia, Mexico, Peru. So these are the countries that have been worst hit in the number of cases. And then in terms of deaths, it may be an underestimate of the number of deaths, but at the moment approaching 1.4 million deaths from this pandemic that's less than 1 year old. In the United States, if we look at the COVID tracking project and look at the 7-day average line, we've now almost reached the 7-day average of COVID deaths in May the 13th. And this is upticking around the country. We don't know individual variation between New York City, New York State, the Northeast, compared to areas in the Midwest that are particularly badly hit at the moment, but its timing is not good for Thanksgiving. If we think a little bit about the virus, just to remind ourselves, I think it's important to remember what we know about this virus. It is a novel coronavirus that has crossed the species barrier to infect humans, but it's not the first. And we know about SARS, the original SARS, sometimes called SARS-CoV or SARS-CoV-1, MERS, the Middle East Respiratory Syndrome virus, and now the second SARS-CoV-2. But these highly pathogenic human-to-human transmitted cross-species novel coronaviruses are on the background of the fact that a third of normal respiratory tract infections are caused by 4 seasonal human coronaviruses. So almost all of us at some stage have had one or more of these seasonal human coronavirus infections with a mild illness. Coronaviruses are the subfamily Orthocoronavirinae. They're enveloped viruses with a positive single-stranded RNA. They have a large genome size, one of the largest amongst RNA viruses. And they have this characteristic surface club-shaped spikes, which create an image of a solar corona, and that's why they're called coronaviruses. So we think about genetic evidence that suggests that SARS comes from animals. We think it's likely to be from pangolins or potentially bats, but I think the true origin is still under investigation, and we may never completely know when that occurs. Some of the first reported cases in Wuhan did not have links to the seafood market. And in France, a stored sample from a patient with pneumonia tested positive. So I think that there are a number of still to be determined investigations that will help, if it can, pinpoint where that species transmission actually occurred. In terms of similarities at a genomic level between SARS-CoV-2 and SARS-CoV-1 or MERS, SARS-CoV-2 has got about 80% genome sequence identity with SARS and about 50% with MERS. So if you look on the right-hand side of the slide here, you can see that between SARS-CoV-2 and SARS, the original one, that they have more than 90% homology or amino acid identity, except for the spike gene, which is the one that diverges more. In terms of some basic pathogenesis of what happens when SARS-CoV-2 virus infects through the nasal oral route, cells in the epithelium and other cells expressing the ACE2 receptor are infected, type 2 alveolar cells, for example. And the viruses have immediate apparent effects on suppressing antiviral interferon responses. And then there's infiltration with monocytes, macrophages, neutrophils, other adaptive immune cells, which leads to a pro-inflammatory cytokine milieu. And that inflammatory response in some people can result in a cytokine storm that leads to more serious immunopathologies. Adaptive cytotoxic T cells are recruited to the site of infection, and B cells and plasma cells can pump out antibodies specific to SARS-CoV-2. And this is ongoing in a number of sites, probably not just only the lung, but also in the pancreas, in the liver, and the heart, and other organs as well. If we think about clinical features of COVID-19, the disease that this virus causes, when we think about clinical features, we tend to think from the mild through to the critical illness, but a variable number of people who are infected with SARS-CoV-2 are apparently asymptomatic, and that they will not show clinical symptoms that they notice in relation to the infection, yet they still are positive and potentially also infectious. And this may be one of the ways that infection is spread most widely. In terms of illness, once an illness occurs in terms of mild symptomatology, there's a change in taste or smell, often fever, cough, fatigue. And then if someone is having a moderate case, then there will be more problems with problems breathing. Even though the oxygen saturation remains at a manageable level, people can have difficulty in breathing. And moderate and mild illness are often managed at home, in the home setting. Once someone needs to go to hospital, it's often because of increased problems with breathing, and the oxygen saturation will dip. They go into hospital, they'll be assessed, they may get sent to the intensive care unit, and they may end up on a ventilator. And those are people who have a critical illness. And I think we're beginning to understand that this time period between infection and development of illness is likely to largely reflect a period of viral replication followed by a period of immunopathogenesis in many people. And the way that this works is one where we might tailor potential treatments according to the time of which interventions are made, with antiviral therapy early on, and then antibody therapy coming in, and then anti-inflammatory therapy such as with dexamethasone, probably no longer so much with remdesivir in later cases. So there has been limited therapeutic availability of drugs for people with COVID-19. So, of course, the world, as we know, kicked into action to try and find therapeutics or vaccines. And COVID-19 vaccination is a critical tool that will be used to stop the pandemic. And one of the developments has been a number of companies that have been invested in by the Department of Health and Human Services, Department of Defense, in what was called Operation Warp Speed. Of course, there are many companies that are not participating in this program that are also actively working on vaccines. And the aim of this Warp Speed plan is to develop tens of millions of doses of vaccine with demonstrated safety and efficacy that have been approved or authorized by the FDA for use in the US population, with the goal of having 300 million doses of vaccines at the end of this year. That's just over a month, 6 weeks or so or less, and deployed by mid-2021. And there are well over 100 vaccines in some type of development. And these come in various species and sizes and shapes. So mRNA vaccines, which would be a new in human first, are being manufactured. The most prominent ones from Moderna and Pfizer. Moderna is part of the Warp Speed program. Pfizer is not. I'll come to their phase 3 results in a minute. But there are other mRNA vaccines not far behind. Then there are DNA vaccines, again, phase 1, phase 2, from a number of different organizations, both from private pharmaceuticals as well as from academic partnerships. And then a phase 3 trial on the Warp Speed for the Novavax recombinant protein, expressing the spike protein. This is more familiar vaccine, adjuvanted, and there are a number of other vaccines in this recombinant protein category. And then once we leave the mRNA, DNA, and protein, we go into viral vectors. There is the phase 3 University of Oxford AstraZeneca chimp adenovirus vectored product, and a number of others that are being tested, including others that are in phase 3. And then inactivated viral vaccines such as the Sinovac vaccine. So there's an intense activity in vaccines, well over 100. And I think when Maddie and I planned this talk, we guessed that there was going to be results coming out. And in fact, we've had results from interim analyses released by the company, not through peer review, from 3 of the phase 3 studies. And the Pfizer BioNTech mRNA vaccine had enrolled over 40,000 participants. It's they tell us that it's more than 90% effective in preventing COVID-19 at 7 days after the second dose. But one of the limitations of this vaccine, outside of its great efficacy, is that it has to be kept really cold in minus 75 degrees Celsius or minus 103 Fahrenheit. And that could be an impediment to rolling out that vaccine. The Moderna vaccine, which wraps its mRNA in a proprietary lipid coat, has less of a problems for that cold chain. It can be kept at minus 20, and even for a period of time at room temperature. That study had 30,000 participants with an efficacy, again, an interim and early efficacy of around 95%. So these are really fantastic results coming out as the first 2 results. And then today, AstraZeneca released its promising data on its adenovirus vectored product. And the headlines you may have noticed said that this vaccine was up to 90% effective. The drug maker actually said that its vaccine candidate was 70% effective. But when you start to delve, and this is why I want you to caution about press releases, is that with the standard dosing regimen, it's 62% effective, which is quite different from the 95% from the Moderna. The 90% effective is interesting because it is a puzzling result where a small number of participants, around 2,500, had received half a dose as their prime and a full dose as their boost. And that appeared to be more effective than the standard dosing regimen. So there's still a lot to be learned. But overall, the good news is the first 3 vaccines are showing some efficacy and are going for FDA licensure under emergency use. And I expect soon we'll hear about that soon. So what we've been interested in is thinking about how can you bridge that period until COVID vaccines are widely available. And stopping a pandemic requires all the tools that are at our disposal. And I think this phrase non-pharmaceutical interventions, or NPIs, has become widely known. And these include the things that we do: wear masks, physically distance, we self-isolate, we work from home, and we shield vulnerable populations. But what I'd like to talk to you about in this talk is there an alternative way that we can help with the bridging period until COVID vaccines are widely available by tapping in to a phenomenon of potential cross-protective immunity induced by non-SARS-CoV-2 vaccines? And I'd like to take us back to some old literature that started us off on this quest related to what is known as viral interference. Viral interference is a phenomenon in which infection with one virus limits or delays infection with a second virus. And this can be intrinsic interference. Viruses could reciprocally inhibit their own infection. It can also be homologous from the same family, heterotypic from the same species, or heterologous from different families. And it's now quite old when this was first described, both in vitro and in people and in animals. And it was thought that this is mediated by a number of different mechanisms, both by interferons, sort of host mediated, and then also potentially virus mediated conditions such as defecting interfering particles or small interfering RNAs, competition for cellular factors. So there's been in the literature quite a few studies that have described this phenomenon of viral interference. But then from an epidemiological perspective, there have been a number of interesting observations which have suggested that the presence of one virus infection in the population has a potential impact on the presence of another. So a couple of examples: the early circulation of influenza H1N1 in Japan or the Netherlands or Hong Kong had an impact on the timing of the epidemics of several winter viruses, predominantly RSV. And the timing of epidemics, not pandemics, the timing of epidemics is often predictable, and this was quite a surprise. And then a corollary was that an onset of the flu epidemic was delayed in France due to viral interference between rhinoviruses and influenza. So this epidemiological evidence suggests that there is a real impact in populations of one virus over another. So we wanted to ask the question, could those infection interferences be replicated by vaccination? And so I'm going to start to talk about what we're calling the heterologous effects of vaccines, and start by talking about some epidemiological studies where in one study, the Department of Defense tested personnel for respiratory viruses and noticed that those that had received the influenza vaccine had a decreased risk of having other respiratory pathogens compared to those that hadn't been vaccinated. And that interference trend was also noticed for coronaviruses and human metapneumovirus. In children, it's been known for some time that the live attenuated poliovirus vaccine can have a potential protective role against ototus media. And perhaps the best known of the heterologous vaccines in the literature is that's used to help prevent Mycobacterium tuberculosis infection with Bacille Calmette-Guérin vaccine. And that, along with measles or polio, can lead to a decrease in overall childhood mortality that can't only be attributed to protection against the target disease alone. So a number of examples. So giving the BCG vaccine has been shown to reduce neonatal mortality by 38% in high infectious pressure environments. And having had the BCG vaccine has also been associated with longer sustained beneficial effects in older children and adults. So Daniela, Nathaniel, and myself coined this phrase heterologous vaccine intervention, or HVI. And the way we thought of it is as follows. So heterologous immunity is the induction of an immune response to an unrelated pathogen upon exposure to a different pathogen. The heterologous or non-specific effects of vaccines suggest that they can affect the immune response to organisms other than their pathogen-specific intended purpose. And heterologous vaccine intervention is the implementation of vaccination campaigns of available non-specific vaccines to induce a heterologous immunity. And we are going to posit that this could be used during an epidemic or pandemic to potentially help mitigate and to buy time for that bridge period until the specific vaccines are widely available. In the literature, other people, of course, have been thinking along these lines, and people have reported on potential cross-reactivity, both mediated by pathogens in the same family. So cross-reactive immunity from those 4 less pathogenic human coronaviruses that many of us probably have had, or mediated by distantly related pathogens or vaccines. So with that as background, I'd like us to think more about the BCG vaccine and what is known about how this BCG vaccine works. So over the past 10 or so years, mechanisms of effect have been better defined, and the phrase trained immunity has been coined in order to suggest that there's more to this vaccine than just stimulating immune responses against its intended target. And trained immunity is a de facto immune memory of the innate immune system, if you like, which enables a stronger immune response to secondary stimuli. And this could be mediated by the induction of persistent epigenetic changes associated with inflammation in peripheral monocytes, release of pro-inflammatory cytokines by peripheral blood mononuclear cells after intradermal BCG vaccination upon restimulation with a different pathogen, or even BCG vaccination inducing a rewiring of the transcriptional programs of hepatic stem cells in the bone marrow. And there probably are both trained immune mechanisms and metabolic mechanisms that constitute the effect of BCG vaccine. So we, of course, are natural skeptics. And so we're thinking, well, this sounds interesting. Could there be any real benefit in the clinical world? So is there any potential clinical relevance? We've heard about epidemiological associations. There's obviously a lot of potential confounders on those. Has anyone done any study that can really prove to us that trained immunity has any impact on a non-related pathogen? And the answer is our timing is good, because we were very excited by last month when Cell published this study as an interim analysis of the ACTIVATE trial. And this is a phase 3 randomized clinical trial of BCG vaccination against infection in the elderly. And it's a double-blinded randomized trial in which 198 elderly patients received BCG or placebo vaccine at hospital discharge and were then followed for 12 months for any new infection. And at the interim analysis, BCG vaccination had significantly increased the time to a first infection, a median of 16 weeks compared to 11 weeks with placebo. And the incidence of new infections was around 42% after placebo, but 25% after BCG vaccination. And most of the protection was against respiratory tract infections of probable viral origin and a significant p-value. And there wasn't any difference in the frequency of adverse events. So this exciting data has suggested in a randomized clinical study that BCG vaccination is safe and can protect the elderly against infections. But at this time, there's no data whether BCG vaccine can potentially protect against SARS-CoV-2 infection, although a number of clinical studies are now asking that question. So is this effect real? How can these biological mechanisms work? So in terms of thinking about the mechanisms for heterologous effects of different vaccines, there may be a number of different related ways in which vaccines might mediate a heterologous effect. We've heard about trained immunity and cross-reactivity. That cross-reactivity could be through T cells, it could be through antibodies, it could be through peptide-based distant cross-reactivity. There could be modulation of regulatory or memory cells, difference in cytokine responses, innate immune boosting, a number of different potential ways that this effect might be working. And when we think about different vaccines, we now know that there are, in the literature, potential immunological mechanisms that could contribute to such a heterologous effect. So I've talked about BCG and trained immunity, and also through stimulating Th1 and Th17 immune responses. For other vaccines, there is also data suggesting that there may be bystander heterologous effects. So with the oral polio vaccine, there's viral interference, there's potentially long-lasting type 1 interferon responses, and maybe even cross-reactive T cells. For the live attenuated influenza vaccine, local innate immune responses, and then boosting in TLR3 or 7 mediated innate immune responses. 10 years ago, Brian Long, a postdoc in my lab when I was at UCSF, showed that after receiving the killed influenza vaccination, there's a transient but real boost in natural killer cell numbers for several months after receiving the vaccine. And that type of boosting of natural killer cells might be one of the ways that an inactivated influenza vaccine might be showing such an effect. And then also there's another study about humoral immunity. Measles-containing vaccines also may cause trained immunity, as well as cross-reactivity, likewise with vaccinia virus. But we also don't potentially take enough into account that the adjuvants in which many of these vaccines are given themselves act as non-specific boosters of immune response. So it might not be all due to specificity or cross-reactivity from the antigen within the vaccine, but it might be potentially related to adjuvants as well. So the question was for us, are vaccine-mediated heterologous effects associated with a low incidence of SARS-CoV-2 infection? And 2 studies have started to look at this. So the first is an exploratory study that's found on medRxiv, in which Pawlowski and colleagues analyzed immunization records from more than 137 individuals who had received a SARS-CoV-2 PCR test. And they found decreased SARS-CoV-2 rates in individuals with recent non-COVID-19 vaccinations, even after adjusting for geographic incidence and testing rates, demographics, comorbidities, and other vaccinations. And when they did an age, race, ethnicity, and blood group stratification analysis, they showed a significantly lower SARS-CoV-2 rate amongst Black individuals who had taken the pneumococcal conjugate vaccine with a relative risk of 0.45 at the 5-year time horizon. So this low numbers even though they started with 137 individuals, and I'm sure that these type of studies will start to gather greater numbers of data, but this preliminary study on MEDARCHIVE has suggested that prior non-COVID vaccination might have an impact on whether people get infected in the first place. And then the second study aimed to evaluate whether there was any relationship between vaccination and SARS-CoV-2 infection, looked at influenza or pneumococcal vaccination. And it's the Italian cross-sectional web-based survey called EpiCovid-19. This was based on a self-selection sample of individuals who were older than 18 and looked at the relationships between vaccination and a positive test using multivariable logistic regression, doing stratification analysis by age. And they showed that anti-pneumococcal and anti-influenza vaccinations were associated with a decreased probability of a SARS-CoV-2 positive test in the younger participants, and a significant lower probability of a positive test result in older individuals who'd received the pneumococcal vaccine. But what about any potential relationship to severity of clinical disease as opposed to getting infected in the first place? So a number of epidemiological studies have shown that BCG vaccination, which we've talked about now quite a bit, is associated with a lower number of COVID-19 cases and reduced mortality. But as I mentioned before, those studies are complex due to inherent biases and multiple confounders. So Escobar, Melina Cruz, and Carolina Barillas Murray published a recent paper in PNAS where they aim to mitigate potential confounding variables by including countries that fulfill the criteria of the stage of COVID epidemic and development, rurality, population density, and age structures. And so they performed a filtered analysis of COVID-19 mortality per million inhabitants in countries with current, such as Ukraine, Hungary, Poland, or interrupted BCG coverage, such as Switzerland or Portugal, or those that had never vaccinated. And looked at countries with similar social, economic, and epidemic stage conditions. And they found a negative correlation between the BCG index and COVID-19 mortality per million inhabitants during the first month of the pandemic in socially similar European countries with different vaccination policies. But what about other vaccinations? So Daniela, Rob Schwartz, and myself looked at any epidemiological evidence for association between vaccination uptake in the elderly and lower COVID deaths. And we used Italy, where the data was pretty robust, and found that for every 10% increase in geriatric flu vaccination coverage, there was a 3% decrease in the case fatality ratio. And another study has now been published, which had similar results, and with their multivariate analysis, their vaccination coverage rates correlated independently with seroprevalence, hospitalization, admission to intensive care units, and number of deaths attributable to COVID-19. And so they did conclude that the coverage rate of the influenza vaccination in Italy in people over 65 was associated with a reduced spread and less severe clinical expression of COVID-19. So what about other countries? Again, this is a global education talk. So this study from Brazil compared COVID-19 mortality outcomes of patients vaccinated against influenza at different time points in relation to COVID mortality. And they looked at odds ratios, again, based on multivariable logistic regression models with full sets of covariates. and they found associations between having influenza vaccination and reduced COVID mortality. So then, what about the United States? Well, in this study from a group of Johns Hopkins and Weill Cornell Medicine, which we didn't know that other of our friends and colleagues were doing similar studies, looked at areal level associations between influenza vaccination coverage and COVID-19 deaths until June the 10th. And they used quasi-Poisson regression models and looked at the number of deaths as an outcome variable, and they adjusted again for a large number of potentially confounding variables at county level, as well as direct adjustments. And their results suggested that influenza vaccination coverage in the elderly was negatively associated with mortality from COVID-19. So I think it's really important to caution all of this data that I've shown you, because there are many confounders that we know about, and there are also, in a Rumsfeldian way, confounders that we don't know about. It could be that individuals who are more likely to get a influenza vaccine who are elderly are less frail, and that frailty bias is well known in epidemiological associations. So we have to be really cautious about confounding in order to make inferences about whether these vaccines themselves are or are not related to the effect seen. However, I'd like to take us just back to that Activate trial, because this to me is a milestone in which a randomized clinical study trial, a phase 3 trial of BCG vaccination, showed a protection against infections from unrelated. So I do believe that these effects are real. So with a plausible mechanism for BCG vaccination, can we think a little more about influenza vaccination? I told you how Brian Long 10 years ago had shown that influenza vaccination increases the number of natural killer cells circulating, and you could imagine that that might help protect against disease severity in some mechanism. But again, timing is everything, and this extremely recent preprint from Mia Natea's group, who really is one of the pioneers of the trained immunity field, did some in vitro studies suggesting that, in fact, influenza vaccination with the killed vaccine can elicit some type of training immune mechanism. So there may be valid reasons why other vaccines outside of BCG, including the killed influenza vaccine, might have on the general immune response. So Nathaniel Hupert, a friend and colleague here at Cornell, who has done fantastic things with mathematical modeling of COVID, came together with Danielle and myself and said, could we incorporate these potential heterologous vaccine interventions with non-pharmaceutical interventions? And Nathaniel is one of the leaders of a program called the COVID-19 International Modeling Consortium, or COMO, program based out of Cornell and Oxford. And this model allows, as models do, to plug in data and understand impacts of data on projecting what might happen to a disease. And the COMO model was developed to look at the effect of what's happening in the infection and estimate the impact of non-pharmaceutical interventions. But Nathaniel and his colleagues in the COMO program could adjust the model to bring in potential heterologous vaccination, HVI, as a way of incorporating that into the model and being able to ask questions from a modeling perspective of what might happen if you bring heterologous vaccination into a situation where you're already using NPI to help protect the population, again, before vaccines are widely available. And part of what I see is this upcoming year of bridging while the vaccines are rolled out. So by using this mathematical model, we can assess the potential impact of interventions such as HVI in the context of ongoing NPIs in both community viral transmission and in health outcomes. So we started off by going back to Germany because the data is really pretty extensive, the really good data collection in Germany that we could use. And you'll remember these studies that I showed from Germany. So what we wanted to do was ask the question and use the Como model to initially estimate the potential efficacy of HVI. And we could do this because we knew that BCG had an effect and was different between East and West Germany. And Germany really provided a unique opportunity to compare the potential effect of age of BCG vaccination on susceptibility to COVID-19, as before unification, East and West Germany had different vaccination schemes. So in West Germany, those 22 to 59-year-olds today were vaccinated, while in East Germany, people who today are between 45 and 84 had at least one dose of the BCG vaccine. So a comparison of those two regions revealed that the average COVID-19 mortality rate in the former West German states was 2.9-fold higher than in the former Eastern states. And another study from Julia Hauer had similar results, and they also emphasized, I think, an important fact that the population with a greater risk of death due to COVID was more abundant in the former East Germany because it's higher proportion of elderly populations. But by looking at this data, we could move on to the next phase, which is to calculate what the impact of that BCG coverage vaccination might have if you took the data from those papers, calculated the vaccine efficacy, and then speculated on what might happen if you went and vaccinated the West German population. So, as I mentioned, in the former East Germany, infants, 15 infants to 15-year-olds were vaccinated from 1951 to 1975. So between 45 and 84 today had been vaccinated. And using the population data of Germany, we calculated an 85% coverage. In West Germany, in contrast to East Germany, infants were vaccinated between 1961 and 1998. So there was no coverage in the elderly population. We then used the Como model to assess the potential impact of BCG vaccination on COVID mortality in the context of ongoing non-pharmaceutical interventions. So we first simulated what these interventions would look like, and then introduced BCG vaccination as an intervention in the model. And doing this, we found a heterologous vaccine efficacy that fit the data of 5%. And then we simulated what that might do in the former West German states. And so in this graph, we're showing that at a 5% heterologous vaccine efficacy, the model would calculate that 5.2% infections would occur without BCG, but with BCG, that would be reduced to 3.1%. And there would be a attributable reduction in COVID mortality. So that's shown, this is what the mortality would have been looked like, and then with the heterologous vaccination intervention at 5%. So we think that this probably isn't about the right ballpark for a single vaccination in the elderly population in West Germany. So what about the United States? So the first thing Nathaniel did was to calibrate the Como model, and he calibrated the model output by looking at reported COVID-19 related deaths and hospitalizations. And you'll see that the model deaths and model hospitalization, or the model deaths from the New York Times versus the actual deaths reported in the New York Times and the model deaths were really very good. And also the hospitalizations from the COVID tracking project, again, the model really performed well. So this calibration of the model was then what allowed us to project the impact of what heterologous vaccine intervention would look like if it was implemented in the United States. And so we modeled what might happen if on November the 1st, now a few days past, there had been a heterologous vaccination intervention campaign in the United States of different percent effectiveness. And this could be one or more vaccines in a pan-vaccine campaign with efficacies of 5, 10, or 15% with different age targets, a 3-week campaign of about 70%. So the first thing that we can see is that there is a projected modeled reduction in mortality when you vaccinate 18 and up, that goes to up to around 15% from a 3-week campaign started on November the 1st. That was less dramatic if the campaign had been in the elderly population only, with a reduction in mortality of around 8.3%. We then modeled the impact on hospitalizations or cases in the US, and really saw quite a impressive impact. Again, it's a model. What you put in and what you get out depends on the model. Is projected to reduce COVID-19 hospitalization and caseload by around 48% compared to if no HVI had been implemented and if HVI had 15% efficacy. And that reduction was reached by the end of December 2020. So I'm going to conclude and sum up what this model has shown us. So what I hope I've done is talked you through the path of thinking about how we can bridge the period between now and when we have wide rollout of the COVID vaccines that are specific for COVID. Non-pharmaceutical interventions have been used, but we think there may be an alternative and augmentative way of impacting caseload, case fatalities, hospitalizations, morbidity by a heterologous vaccination campaign. And in our model, we have shown a potential additive impact of HVIs when combined with currently implemented MPIs in the US. And given their history and safety profile, BCG and or influenza vaccination could be targeted to all individuals 18 years old and older to immediately reduce caseload, healthcare utilization, and mortality. Combination vaccination strategies to achieve a better percentage efficacy might involve using age-recommended vaccines, basically a pan-vaccination campaign. In view of the urgency of the current pandemic and the time it will take to roll out the new COVID vaccines, the benefit of these interventions likely outweigh their risks. And in addition to their solely health-related impact, they also might have influences in mitigating the severe social and economic effects of lockdown policies. HVIs with age-appropriate vaccination campaigns may not only be useful for the current pandemic, but also might be a harbinger of how we could potentially react quicker in any future inevitable pandemics through immune boosting of the population. And so we would like this to be considered as part of the discussion thought process for pandemic planners in considering what such interventions might have alongside non-pharmaceutical interventions in future public health response planning. So I'd like to end by just bringing up the people who really made this happen, particularly the initial work with Rob Schwartz and Daniela and Nathaniel, who also have been just an incredible pleasure to work with. And thanks much for listening. So I see that there are questions in chat, which I will try and answer. We only have a few minutes left, so I would like to again thank Maddie for the invitation. Hope people have had a chance to think more about heterologous vaccine interventions, and like to wish everyone a great Thanksgiving, and really appreciate everyone's attention. So I will just stay on for a little while to answer questions in chat, and thanks everyone for participation.
Thank you, Doug. Thank you, Dr. Nixon, for really a very compelling talk. I'm wondering if you could get us out of the stop, or if you could stop sharing the screen so that we could, there we go, and maybe come live and so forth. There are a lot of questions. I'm going to take the host prerogative just by asking what your thoughts are with the Suleiman et al. Piece, where they are part of the Oxford COVID-19 evidence service team in Oxford, and they did a very nice systematic review looking at the use of BCG vaccination and could it be used for COVID? And they in their systematic review tended to find that there was a lack of evidence that this particular vaccine protected against COVID-19. They also go on to say that there are ongoing trials and so forth, but they said no.
Absolutely. I think that's why we're so excited that someone has actually done a clinical trial activate of BCG, albeit it was not set up to look at COVID-19. There are a number of other trials that are coming up. I also hope that I stressed the importance of considering the limitations of the epidemiological associative studies based on confounding. And that's why I am so excited, although we have not yet seen a clinical trial of BCG deliberately designed to prevent or ameliorate COVID-19. The preliminary results from the ACTIVATE trial suggest that BCG vaccination does protect against other respiratory viruses, including other coronaviruses. So we don't know. I think it's incredibly important to be both skeptical as well as optimistic, but make sure that the data is developed in a rigorous way.
Right, and maybe we could go focus on Brazil. Our colleague from Brazil, Dr. Weber, is online, and she said that BCG is still mandatory in Brazil. So maybe we should go down to Sao Paulo again and see what we can
find. I think the other clear effect is that Brazil has a very impressive vaccination program, and they accelerated the influenza vaccination campaign. And we've just heard people still get BCG vaccine, yet a lot of the population has still become infected. A lot of people have become sick. So we know that this is not a simple equation. It may be that, as from our modeling, that this may have an impact in a certain number of people for a variety of reasons. But one thing to be noted down in Brazil is that with the Southern Hemisphere having different seasonality of influenza, their vaccination campaign and getting people vaccinated against influenza is important and will be here soon to prevent all those influenza-related visits to the hospital and to worry about whether people might have multiple respiratory infections. So I think the message that I'm hoping comes out of this talk is a reevaluation of getting people vaccinated against vaccines that they probably should have or have forgotten to have recently, and potentially that might have some benefit while we are waiting for the real vaccines, which are coming to come as quickly as we can get them.
Yeah. You have a number of questions. I don't know if you're going to actually be able to get to all of them, but if you could check the chat and pick and choose from those questions, that would be helpful.
Sure. So there are many great questions. I would encourage everyone to, I know some people can stay on, some people can't. I've got another few minutes I can stay on. To just email me, please, dnixon@med.cornell.edu. Happy to do it. So I think one question from Mirella is really important. How long can trained immunity last? Trained immunity can last for a long period of time. There's actually been a number of different studies that have suggested that trained immune impacts from BCG vaccination might even last for 40 years. We tend to think that there's probably going to be a number of staggered impacts of trained immunity longevity, from a year to 5 years to longer. She also has an interesting question about potential interference between the mRNA vaccines that are just coming. I think, these new mRNA vaccines are terribly exciting and quite new, and time's going to tell what they are going to provide. We now know that within warp speed, the Novavax vaccine is going to report soon. AstraZeneca today with the adenovirus vector. So there are alternatives to the mRNA vaccines, but yeah, I think it's a very exciting time, both in specific vaccines and non-specific vaccines.
Yes.
Okay, so I think looking at the time, I will now step out, but anyone who has a question that we didn't get to, please do just email me. Happy to answer. And really, Maddie, thanks for the invitation. Thanks for your prescience in knowing the right time for the talk. And as I said to everyone, please have a wonderful, safe Thanksgiving. And if you haven't had your influenza vaccination, it's time to get it.
Right. No, thank you so much, Doug. I'd like to take credit for the timing, but
please
no.
Okay. Thanks, everyone.
Thank you so very much for joining us. Thanks, everybody, for participating in this. And I agree. Have a safe and happy.
Thank you very much. Bye.
Take care. Thank you. Okay. Silke, good to see you. All right, everyone, have a safe, lovely evening. I am signing.